So I want to welcome everybody to the Robert Wood Johnson Foundation Interdisciplinary Nursing Quality Research Initiative National Conference. My name is Lori Melichar, and along with my colleagues at the Robert Wood Johnson Foundation and Drs. Mary Naylor and Mark Pauly, want to welcome you to Washington, D.C. We are here to celebrate. We at RWJ are just so proud of what this program has been able to accomplish over the past 7 years and is poised to contribute in the future. We're also here to share some of what we've learned over the past 7 years of INQRI. Research and evaluation has always been a priority at the Robert Wood Johnson Foundation. We spend a higher proportion of our budget on research and evaluation activities than almost any other foundation. This program took expectations about the quality of research up a notch by requiring interdisciplinary research teams who could produce findings that were rigorous and relevant. We are very proud of the fact that interdisciplinary teams were created, nurtured, and sustained through our program strategy. We are proud of the extensive partnerships this program has fostered to address national healthcare issues through our annual meetings. But this program was created to produce impact and to improve the quality of care provided in the United States. And we are more proud that thanks to INQRI, researchers at the University of Minnesota can tell you how nurses can improve outcomes of patients with heart failure. A team from Yale University can show you how visiting nurses can improve diet and exercise of at-risk, low-income adults. If nurses do what a team at Johns Hopkins Hospital has demonstrated, more patients will take their prescription medicines. Researchers at Columbus Children's Hospital can tell nurses how to best support children during vulnerable times. And a team at Brigham and Women's University can show nurses and administrators who support nurses how nurses can reduce falls for hospitalized patients. And these are just a few of the actionable results that INQRI research teams have produced so far. All INQRI-funded research has focused on the contributions of nurses because they are the largest group of healthcare professionals that provide direct patient care, are an integral part of the healthcare team, and are a pivotal nexus to improving quality in many settings. And you'll hear more about the impact the INQRI research has had on quality over the next 2 days, and you'll need to stay tuned to the newly revamped INQRI.org to keep up with the results that the teams will continue to produce and publish long after they leave today. INQRI is but one program of the Robert Wood Johnson Foundation's portfolio of programs focused on quality nursing care. The foundation has invested over $160 million over the past 30 years in nursing directly. 6 key goals have shaped our mission and the framework for our programs: to build the nursing field and profession, to support and improve academic medicine, to attract and retain high-quality nursing staff by improving working conditions, to improve the organization of work and use of information technology in nursing, to inspire improvements in the physical design of healthcare facilities. And we seek to enhance nurses' ability to serve as healthcare leaders while creating a healthcare culture that looks to nurses for leadership. These goals drive all of RWJF nursing programming, but nowhere have these goals been more transparent than in the funding of the INQRI program. Led by nurse leader Dr. Mary Naylor and our interdisciplinary collaborator, Dr. Mark Pauly, this initiative has sought to provide evidence of the link between nursing and quality. And it has developed sustainable systems to ensure that the field continues to generate evidence of this link. This program has created a foundation for improving the care that nurses and their teams provide and the quality that all patients receive.
What was the impetus behind INQRI? So everything starts with a story. I received a call in late 2002, early 2003, from Ellen Kurtzman, who at that time was a project staff with the National Quality Forum. The Robert Wood Johnson Foundation had sponsored an initiative, a 14-month project that was designed to have NQF take a critical look at the evidence linking nursing and quality and to identify the measures, robust measures that captured nursing's contributions to quality. So I receive a call from Ellen, and she starts as any good person does. You don't know me, but I'm a Penn graduate. And greasing the wheels, I say, okay. Honestly, I knew nothing about the National Quality Forum. I now sit on its board. I knew nothing or very little about the notion of quality measures, endorsed quality measures, although our team had been measuring impact of interventions on quality for many, many years. So I was encouraged to join this group. I co-directed it with Lele Galinas, Vice President and Chief Nursing Officer for the VHA, and with the incredible support of Ellen and others, we began to take a look at what we knew and what we didn't know. So I was there sort of as the arbiter of taking a look at the science and the challenges that lay ahead. And the bottom line was that in many, many areas we thought we knew a lot, but there was little compelling evidence to support nursing's link to quality. And even where we had evidence, we didn't often have robust measures to capture it. Lori Melichar is sitting as the program officer for this initiative, and that's how I began to get to know Lori. She then invited me to a dinner in New York, and this may tell a little bit about the two of us, but we arrive, and we sat at opposite ends of the restaurant for a long time. I had left my cell at home. Lori, I'm sure, was texting away. And finally, we decided we'll get motivated to get up and look around and see if we can find each other. And that began our INQRI partnership. NQF produced a report on the National Voluntary Consensus Standards for Nursing Care, but it equally produced a research agenda about gaps in knowledge at that point in time. Lori then convenes a meeting of leaders. Many of you in this room might have been at this meeting in Princeton to say, here's an agenda. What are our best opportunities to move quickly in accelerating and addressing the priorities on this agenda? And that is where INQRI was launched. As a result of that meeting, we established a number of priorities. We were, the first year, we said, well, the first thing we need to do is to begin to address the gaps in measurement. And the first call for proposals focused on what are core measures that people care about, care coordination, pain management, others, that we should really focus on building these measures that are scientifically acceptable, that meet all the tests, and would enable ultimately to have endorsed measures through the NQF process. We also that year did something pretty interesting. We had the call for proposals ask the question to people, consumers, what do you think of as quality? And those were the two major areas that we started to focus on in our work. In subsequent years, we took on other areas where there was a dearth of evidence linking nursing to quality, areas that some of you were participants in and responded to. Each time, we wanted to link these areas to national healthcare priorities. So we took on the issues of how do nurses contribute to reductions in waste and improvements in efficiency? How do nursing interventions improve the value of patient care? And then our last group of fundees helped remind us that we were not just about generating knowledge, but we needed to focus on how it is that we learn how to implement evidence-based interventions into the world. So that's how the program, over its 5 years since the start of these funds, got growing. We think, based on available evidence, that we are generating compelling findings that suggest, and in many areas are pretty convincing, that nursing is central to high-quality patient care. Findings from our projects are helping key decision makers. They help to inform the Affordable Care Act. They're helping to inform the way that we define measures, such as care coordination, where Jerry Lamb co-chaired the National Quality Forum effort on care coordination and was one of our first grantees, her team, in figuring out how to measure it. We are working on multiple fronts to both make sure the evidence is out there and make sure simultaneously we're using it to affect change. Since 2005, we have funded 40 interdisciplinary teams across a range of contexts. We started to focus just on hospitals, but quickly decided we need to be looking at nursing's contributions in all contexts. The teams have employed diverse methods. Many came to us and said, we want to run a randomized clinical trial, and we said, yes, but additionally, take on the qualitative challenge of trying to uncover through this work what it is that nurses contribute to those outcomes. What are the specific core components that nurses bring to that? For some grantees, this work was a natural extension of work that they had already started. For many, it afforded and in fact insisted upon bringing in younger scholars, bringing in scholars from other disciplines. For others, it was like being in a marriage matchmaking event where people called us with good ideas from one discipline and we matched them with scholars from nursing or another discipline to conduct work. And so for many, it was the first time they had ever worked together on teams to accomplish this work. What is most important, and we are tracking and exciting to us, is that it's not the last time, that these teams are continuing to grow and build. Our goal was to build a field as well as to build the evidence aligned with that field and to move that evidence as quickly as possible in all of the contexts in which we can. Our grantees, I will tell you this was a big challenge for us. Our grantees, the area of dissemination, many of you will recall, was a big challenge. When we received our first groups of proposals, they had in common, the best of these proposals had in common the following: really significant ideas, really exquisite methods. Some needed to be nudged along in terms of bringing the right team members, but what many shared in common was that they put as their dissemination plan, and we're going to talk at conferences, and we're going to publish papers. And we said, we want you to do that. We really care about that, but that is not enough. You have to figure out who it is that you can partner with, other people, consumers, patients, advocacy groups, et cetera, associations, professional societies. With whom can you partner to move your findings quickly into making a difference and having an impact? And so that was a journey for many of you. I saw some smiles in the audience. But we want to tell you a little bit of what we've seen so far. So far, since our launch, and these were first call for proposal, 2005. 2007 is the first year, and I should mention and congratulate all teams because we set as an expectation no extensions. No cost extensions. That was a rule that we held fervently. We want you to produce evidence in these 2 years and don't hold us back. And you did. So since 2007, 2008, we're seeing the first publications from the first group of teams in Cohort 1, and to date, 44 articles in 27 journals, including top-tier journals such as the Journal of the American Medical Association, Health Services Research, Medical Care. The news is getting out there in all the ways that you said you were going to do that. But most importantly, we're seeing your work in many, many other impact areas. But let me just tell you first about some of these pubs. Doctors Dykes and Middleton's project, Translating Fall Risk into Interventions to Prevent Patient Falls, has resulted in a number of publications, including their article in JAMA, which produced evidence from a randomized controlled trial that toolkits and decision support interventions reduce falls in hospitals. Falls are a leading cause of death, disability, costs. Doctors Dennison and Newhouse have had multiple publications in Circulation, Heart and Lung, Journal of Nursing Scholarship, all of which have provided support to the leadership role of nurses in influencing the care of heart failure patients in rural communities. In both health services research and medical care, Drs. Weiss and Yakusheva's team published important pieces on nursing's contributions to high-value healthcare. They found that the quality of nurse discharge teaching had an impact on patients' readiness and readmissions. Furthermore, their teams have had impact on publishing what it is and what it takes to implement that type of intervention in a number of journals, including Geriatric Nursing and the Journal of Clinical Nursing. Drs. Resnick and Zimmerman's team's publications in the Journal of the American Medical Directors, Geriatric Nursing, and others have helped us to understand what it takes to improve physical function among older adults in assisted living facilities, to improve their physical activity, muscle strength, psychosocial outcomes, while decreasing adverse events, pains, falls, and hospitalizations. In a person-centered healthcare system that we are all talking about these days, pain management is a huge priority, a bigger issue than any of the top 5 conditions in this country. Drs. Beck and Berry's teams published work in the Journal of Pain, Nursing Research, and Oncology Nursing Forum chronicle the development of a nurse-sensitive measure of pain management, which continues to be used both in clinical systems and in research, all of which is aimed to improving the processes of care that decrease pain. Drs. Corbett and Setter's team have published in Advances in Nursing Science and Geriatric Nursing, providing critical knowledge about the role of nurses in medication management in people's homes. Just recently, the American Journal of Nursing published Dr. Letvik, Gooms, and Gupta's important work providing the business case for nursing on healthcare quality and safety. They found that when nurses come to work sick, the notion of presenteeism, that this has major negative effects on the quality of patient care as well as cost. But our goal is not just to get the knowledge. It's to make that knowledge readily used by all that can. So we want to absolutely shorten the time from knowledge discovery to implementation. Lori mentioned Dr. Thompson's and Marsteller's work, first clinical trial testing nursing's contributions in the reduction of central line bloodstream infections. More importantly, or equally importantly, colleagues of theirs, Dr. Chan, and colleagues who've now published what it takes to implement evidence-based approaches consistently, reliably, insistent to accomplish these goals. I think that INQRI has made extraordinarily wise investments, or has been extraordinarily lucky, but these are interdisciplinary teams who maybe didn't get it at once, but honestly have really gotten it over time. That their work is not about just accomplishing study aims, but that they have an obligation, accountability, to making sure that whatever they learn, if it can do better than what we have today, needs to move forward. INQRI teams have been able to leverage their funds to secure grants from other major leading supporters of nursing research, and I'm thrilled to have Pat Grady in the audience today, who has been director and a trusted, wonderful colleague and friend of the National Institute for Nursing Research, a partner in efforts that we've had, and also someone, an organization that continues to leverage resources in a similar manner. So we are still awaiting many outcomes from ongoing work. Our last team was funded in 2010, but we thought as a program it was an ideal time for us to begin to look at the whole program. And we began to think about how to do that and wanted to share some of what we are learning. We thought it might be a good idea to take a look at what was the state of knowledge development and the use of interdisciplinary teams and where nurses publish their work pre-INQRI, and what is it that we are learning as we continue to move that knowledge forward. And so enter Ellen Volk and Adam Lustig, who joined us in this extraordinary systematic review of 2 years of science, 2004, the year before INQRI launched, and 2009. And a draft of the paper that we produced as a result of their review is in your packet. But what we were looking for was obviously, this is not causal linkage between inquiry and science and the field, but rather what are we seeing happening in the field? So as we look to 2010, 11, 12, so on, we can begin to see, have we spawned, have we ignited the kind of movement that we've been talking about? So let me tell you a little bit about what we learned. Again, this is a snapshot of 2 years, reviews of thousands of articles that had to meet rigorous criteria to let you know what we are learning in this beginning effort to say, did we make a difference? Of course, we have a long way to know. Here's what we know. The literature shows that we are increasing the volume of studies. In fact, between 2004 and 2009, this is just these 2 years, the number of studies increased in this field by about 70%. There was an increase in the rigor as evidenced by increase in the number of studies that used really robust methods, including randomized clinical trials, that assessed fidelity of interventions and a number of other criteria. And finally, the number of interdisciplinary efforts, the number of interdisciplinary teams conducting studies between these 2 periods also grew. In each year, we looked at 3 broad categories: non-experimental, quasi-experimental, and experimental studies. And there was an increase in the number of studies demonstrating the link or association between nursing and quality in all 3. So here this tells you, looking at non-experimental, most of the studies, more of them earlier in 2004 than in 2009, showing in a non-experimental design, predominantly looking at characteristics of the nurse environment and staffing associations with quality. Most of them showed a positive association. Taking a look at quasi-experimental designs, you'll see an increase in both the number of studies and an increase in the nature of those studies. Nurse-administered interventions, interdisciplinary team interventions in which nurses played a central role, application of technology, and interventions that were targeting either nurses or teams in improving quality. And this shows you where there were no changes in those studies. And then finally, in the experimental category, again, increase between 34 to 52 in those 2 years. Positive association shown in these types of interventions, no difference in 8 compared to 5 studies. So this, again, gives you a sense of what we're learning. Equally important is that in looking at these studies, we, in 2004, are looking at studies published in 80 unique journals compared to 2009, 148 unique journals. A 60% increase in the number of papers in which nurse scholars were the lead author. And most importantly, a real growth in the number of articles published in interdisciplinary journals. So, what is this telling us? It suggests to us that things are moving, but this is just the beginning of the conversation. I think that what it also suggests to us is a continued need to foster the kind of interdisciplinary collaboration that INQRI and other programs are using, to make sure that we are promoting standard measures of quality and value, and to really begin to look in depth at that quality-cost trade-off that Mark Pauly made me begin to look at almost 30 years ago. What is it that we're seeing in terms of benefits versus investments made to achieve those benefits?
So yesterday, Mary shared some of the background of INQRI and told some of the stories about how we got from there to here. I've got a few for you, too. Of course, the overall objective is the cosmic goal of trying to improve the quality of healthcare in the United States, with particular emphasis on the contributions that nurses can make, either to improving it or in some cases not improving it, worsening it. And we wanted to generate through the program, and the foundation wanted to generate rigorous evidence in support of the view that what nurses do have a lot to do with what health outcomes would be. A second dimension, though, this is the I in inquiry, that was, when we started it, at least as far as we know, fairly innovative, was to go beyond lip service, really, and to put in place a number of concrete steps that would make sure that the work that was done here was interdisciplinary and, frankly, not just nurses talking to nurses, but people talking about nurses to the whole world. And so that's the I in inquiry. And I usually deliver a sermonette on the subject, as I said, and this is my last version of it, where I talk about sins and temptations to avoid and slacking off on the idea of interdisciplinary research. After the session yesterday afternoon, I really feel intimidated about criticizing, although I suspect, or even about offering advice, because the realization of the interdisciplinarity of the program that was described yesterday afternoon was, in fact, so much ahead of our aspirations. There's not much more I could say. So if everybody, not only now and in the future, continues to behave as those teams did, you can tune out for the next 10 minutes. But just in case you are not a long-term participant in inquiry but are hearing about all of this for the first time, I do get at least to tell you why I think interdisciplinarity is important and what it means to me. And of course, we hope that the goal of that the model of interdisciplinary research that we've pioneered here will well outlive the inquiry program itself. So I'm going to make a few comments about all of that. So just to kind of go back to basics, we wanted to make the program wanted to make a contribution to the national discussion on healthcare and quality, and there were two basic premises that undergirded this whole effort. The one was the kind of obvious one, I think, to most of the audience here. The nursing workforce has the skills, knowledge, and desire to play a major role in achieving high-quality, high-value health care, if only their contributions can be optimized and channeled in the best possible way. The second is a little less obvious. This meant a lot to me. I know it meant a lot to Mary, too, which is everybody knows that. At least everybody here knows that, and I think most people would say it, but it's the difference between saying and proving. And particularly in medicine, there is a tradition, thank goodness, of evidence-based. There is the art of medicine, of course, and I have to tell you on my Wharton side, management in other industries is not necessarily based on randomized controlled trials, although you would be surprised at how sophisticated some of the work in marketing is. But still, there is a different model in medicine, but it's our model, and so our thought here was that the inquiry program ought to strongly embrace the model of rigorous proof within, of course, the limits of common sense, in order to not just say what everybody knows to be true, but to prove it beyond a shadow of a doubt for those malingering doubters who might be out there. So that was the overall objective, and the premise, which I think has turned out to be true, although it still needs to be pushed forward. You'll hear some of it later on this afternoon when we talk about the business case. That's the session, incidentally, where I'll try to bite my tongue, but I'm bound to say more research is needed, even though the program is over. But the premise is that the rigorous scientific evidence is going to be persuasive in making it possible to bring about needed changes, not only in the healthcare system as a whole, but also in how nurses are used and use the healthcare system. So that's sort of the premises behind the program. Well, what is the I in inquiry for? So here's the corny joke. The reason we put the I in inquiry was because if we didn't, the acronym would have been INQRI, and we didn't want to run a rinky-dink program. Seriously, folks. The real reason was that we not only thought it was important, but we thought that we were going to try, and I hope we partially succeeded. I'm convinced after yesterday that we did, in pushing the idea of interdisciplinary work forward more than usually is the case. So I'm going to run down the competition for a minute. So I've been interdisciplinary myself for many years, and what does it mean, and what did we want to avoid? So we wanted to avoid interdisciplinary research as a platitude, which, again, I know most people are aware of. Everybody is doing interdisciplinary research, especially if there's funding for it. What I do must be interdisciplinary. I read a sociology journal once in my life, so that ought to do the trick. And we wanted to get beyond platitude. We also wanted to get beyond just aspirations. Of course, we want to, and sometimes this gets a little bit into the substance of things. We bring in people from different disciplines, and we hope, beyond the disappointment that we naturally expect, that somehow they will work and play well together. Occasionally that happens. It's the Lord's work when it does, but many times, even when people are brought together, the spark doesn't automatically ignite. The collaboration does not automatically be implemented, and people go back to their offices and do their own thing. So we wanted to get beyond the aspiration and the platitude version of interdisciplinary research into real interdisciplinary research. And the teams last night didn't need it, but I have to tell you, I won't name names, but there are a few of our teams where from time to time in a case, we felt we had kind of a gentle gun to their head in terms of interdisciplinary research to continue what you promised and to make it real. So that was an important feature of the program. The third kind of interdisciplinary research, this allows me to retaliate a little bit against what Mary's remarks yesterday afternoon, has to do with we wanted to avoid sort of the carve-out of interdisciplinary research. And to an economist, that means I write you in my grant for the last 3 months where we'll deliver the data to you, and then you do whatever you economists do with the data, and that's it, and that's the extent of interdisciplinary research. Now, as Mary mentioned yesterday, I have congenitally been unable to say no to proposals for research and research collaboration. That is because I believe, and I tell my PhD students this all the time, almost anything's interesting if you get into it enough. So, don't spend your life trying to find the self-writing PhD topic. That's going to be dumb anyway. Just pick something that sounds kind of intriguing and go with it. There are a few studies of cost effectiveness that I would say never do get interesting, but for the most part, I think that's true. So I don't say no, but the other thing that goes along with that is then I put my nose into everything. So I didn't just want to be the guy, the glorified accountant with more charisma that calculated the cost. As an economist, I wanted to know about what was the original design of the program, what are our outcome measures, how are we handling set-aside costs, which is the trade-offs between risks and benefits, medically speaking, and so forth. So again, the thing to be avoided, and that we tried very hard to avoid in the design of the program was, yes, we have a technical collaborator, but they go off and do their thing, and we were attach much more value to proposals that propose to, and then we tried to help people do what they promised in terms of having real substantive collaboration from the beginning to the end of the project. So that was sort of the idea. I would also say, I was thinking about this when John Lumpkin asked his somewhat provoking question. You should have seen the proposals we turned down, where people didn't get the idea of what we really meant by interdisciplinarity. They also didn't get the idea, as Mary mentioned, of what we really meant by dissemination and making these results operational. But present company, of course, much accepted are people who really did get it. So I think that's sort of what I think we wanted to avoid. And of course, as people here who have been grantees know, we did that in part by requiring that there be 2 PIs, one a nursing PI and one a non-nursing PI. And as I've already mentioned, we tried as far as we could to make sure that both of those people and those whom they represent were integrally involved with the programs as they moved forward. Now, I do have to say a little bit of mea culpa here. Actually, I think we never got quite so far as to write software, but we found ourselves, when we would write up things about inquiry, wanting to use the term nursing quality. I hope I won't insult anybody here, but our philosophical point of view was there is no such thing as nursing quality. There's just quality. And nurses contribute to it, and physicians contribute to it, and pharmacists and social workers, but it's all the same quality. There's no kind of parochial pat-on-your-head nursing quality measure that we want to optimize. We want to optimize real quality. But we found ourselves writing in nursing quality when we weren't too wide awake when we were writing some of that boilerplate, and we had to keep going back and correcting ourselves. I think we did. I suppose at the end we may want to review all the inquiry materials and see if we ever used the forbidden words nursing quality. But we are very much interested in defining quality as something that is majorly affected by nursing, but is not defined just by the limits of nursing, if people want to put limits on nursing, as you know some do. Present company, again, I suspect, accepted. And I think we're pretty much on the way to doing that. At least I felt really good yesterday afternoon, and looking back over the program, that in terms of substance, the projects came out with conclusions about real quality that matters to real people in general. The publication record, Mary put up some of the logos yesterday, is a kind of concrete manifestation of that. I remember one of the early inquiry meetings, we had a panel of journal editors. And we had an editor of a medical journal, who will go nameless, who was asked, do you think it would be a good outlet for publications from the inquiry program to publish in top-line medical journals? And in the kindest possible way, he said, I don't think that's too likely. Well, he was wrong. And I hope people will continue to publish in JAMA and New England Journal and other medical journals, JAGS and so forth, with the results from the inquiry work. And then I wasn't quite as worried about this, although I guess I could have been, and I could have been just as snarky as that guy by saying, how about in health services research and health economics journals? But we do have publications of inquiry teams in health services research, the journal, and it is the journal in health services research. And I just heard one of our teams, sort of a proto-inquiry project, but this is really taking it home, is going to publish some of their results in the American Economic Journal. This is the new journals from the American Economic Association, so you're up there with the big boys and the and girls, and the high priesthood of economics when you're publishing there. So about all I can say from a sort of sermonette hortatory point of view, my homily would say continue the congregation to follow in those paths. Sort of looking toward what's next, or what will make me really sleep well at night about the inquiry program. Again, there's a lot of lip service given to interdisciplinary research. But often when you sit down with a young faculty member, not yet tenured, you say, let's get serious. You need to publish in the journals in your field. This other stuff, it's nice, but this soft, flaky stuff, if you have spare time, but not really. I think, so I'm going to give an example of something that's a little bit ahead of us that I hope we can emulate in the interdisciplinary research in nursing care. I didn't say nurse quality. So behavioral economics, this is sort of inside baseball from my point of view, but there is a hot new avenue of economics called behavioral economics, which, believe it or not, is based on the assumption that your mother could have told you that people don't always maximize constrained utility when making decisions in this world. But for many years, it was kind of a backwater, and you would counsel people who were interested, be careful about that. I mean, you're publishing in a psych journal. What's the matter with you? You'll never get tenure for that. Then what happened was, first, substance. A lot of really great work was produced. And second, the people producing it eventually got to be tenured and positions in a high prestige institution, and all of a sudden it's the hottest thing on the planet. So I am hoping that the same thing will be true of interdisciplinary research on nursing care for the future. I was thinking there is no interdisciplinary journal of nursing care. In a little bit, it's an oxymoron from what I've just said, because it's supposed to be just quality. But I hope that there'll be some dedicated publication outlets to turn the nascent movement into a real revolution. So here's hoping, and I really do want to express enormous gratitude to, first of all, and most importantly, the teams that helped us do not only what we wanted to do and then some, and then of course to Mary and Lori and Heather and all the people at the foundation and our communications people who've been enormously helpful too, especially a distracted full professor in trying to get this to happen. It's been a wonderful experience. Okay, so I think that's mostly what I wanted to say in terms of my reflections on what's the meaning of the I in interdisciplinary. I guess I do need to say one more thing. This is again, more research is needed, or future research. One of the things I'll say I think Mary maybe thought of this. I had thought of interdisciplinary research as kind of what my people do, which is methodological research, and the idea that research on health services or health care and quality is buttressed by the use of people and the inclusion of people who have a strong devotion to rigorous statistical methods and methods of evidence. And so a number of our interdisciplinary teams included people like that, including a number of my friends here who, thank goodness, agreed to be part of this. What happened, though, to some extent at first I felt, well, okay, let's say it's all right, was to a lot of people in the field, interdisciplinary meant other health professions. That wasn't kind of what I had in mind. But I have to say, thank goodness, and this is often the case, it turned out great anyway. As you heard yesterday as well, a number of the projects involved very serious involvement of people in other disciplines with nursing. Our first projects really were much more narrowly defined, things that nurses more or less totally do, or control, like pressure ulcers and fall prevention and so forth. But as the program expanded and as we got a number of really great proposals that interpreted interdisciplinary in terms of inclusion of other health professionals, as long as the research methods were solid, we said okay, and they've turned out to be great. So there is, I think, actually a bit of a titanic struggle going on in the American healthcare system. I hope Zeke will say something about this. I'm not sure how he feels, between what might be called the guild cartel model. Every profession has their own little piece, and of course that's the bad model. The good model is the teamwork model, where we all work together, but there isn't necessarily an automatic designation of certain professions as the quarterback of the team. In fact, the football model may not really be the right sports model. I won't go into any more sports metaphors here, but you'll be happy to hear. But my point is that I think INQRI actually made, at least from my point of view, a substantial contribution to better understanding of that kind of team-based interdisciplinary model. And then, of course, more research is needed. We need to use some rigorous methods to evaluate how all that team activity works. I actually did do a project on this once. I'll give somebody the citations if they want, but the main purpose of the project, it wasn't particularly in healthcare, but it was, how do you measure teaminess in different jobs and professions? And there is a way to do it. There's actually a fairly technical way. The intuition is pretty straightforward. You're a team if when somebody calls in sick, the whole works collapses. You're not a team if when somebody calls in sick, it just means somebody's desk isn't occupied. That was the less elevated version. But again, I do think that there's a lot of possibilities for future research on teamwork in healthcare, much of which I hope will harken back to INQRI as the thing that got it all started. So those are my remarks, and I think I had better do the shout out and then have the great pleasure of introducing Zeke Emanuel. Proof of the both the interdisciplinarity and the quality of the research from our teams is in their findings, and the consequences, at least we'll attribute them to INQRI, even though that violates our rule about rigorous proof of causation. But some great things happen to people on our INQRI teams, which we're happy to take some partial credit for, and I thought I'd mention a few of those now before introducing Zeke. Two of our graduates have gone on to become nursing school deans, John Welton and Jean Johnson. A little bit of over to the dark side, but I know they'll do a great job, and that's a wonderful thing. As a result of a chance meeting at one of the INQRI meetings, grantee Tracy Yap was recruited to become part of the faculty at Duke, and so this is a bit of a Lori's a labor economist, you heard, so we created a bit of a labor market here. Sean Clark has become the inaugural holder of the RBC Chair in Cardiovascular Nursing Research at the University of Toronto and the University Health Network. Jerry Lamb, an INQRI alumna, has served on the National Quality Forum's Technical Advisory Panel on evaluating efficiency across episodes of care. I think I said that in one breath. And currently co-chairs NQF's Steering Committee on Care Coordination. Robin Newhouse has been appointed to the Methodology Committee of PCORI. And, wait a minute. Mary Beth Happ was appointed to the University of Pittsburgh Medical Center's Health System Chair in Nursing Science. Mary Wakefield was named Administrator of HRSA. And just last week, Doug Hooley, Joanne Dish, and Katie White learned that their paper on co-professional leadership was nominated for the best paper, doubtless it'll win, at the 8th International Organizational Behavior and Healthcare Conference in Dublin. So maybe we could give a round of applause to both INQRI